Okay, great. So welcome to our webinar presented by Manhattan Psychology Group. My name is Andrew, and I am the Professional Development Coordinator here to help host and MC tonight's webinar. So whether you are here live today or asynchronously, we're super thrilled to have you join us here today. And if this is your first time joining us, welcome to our webinar series where we host these monthly informational sessions for parents, caregivers, and providers like you guys. Some reminders before we kick off tonight's webinar. Tonight is one of our first dual certification webinars that we are providing. So for BCBAs who are here to earn the CEU, we will be posting two code words during the webinar. So make sure that you are looking out for those code words because you will be needing them to submit the post-webinar survey at the end of the webinar. For psychologists, we are also offering a CEU for you guys tonight. Code words are not going to be necessary for you guys. You are going to have your own special CEU quiz. So after you finish the post-webinar survey and that quiz and obtain 100%, you will get your Psych CEU. The recording for tonight's webinar is going to be posted within a week. And if you are looking for the slides for tonight, we can share it with you after the webinar. Before we get started, I want to give you guys a little rundown of MPG. We have been around since 2011, and we are a group of over 200 adult and child psychologists, neuropsychologists, BCBAs, and special educators. We offer various settings. We are virtual and in person on the Upper West Side in Manhattan, and we serve the greater New York City metro area across all 5 boroughs. We provide wraparound care. That's one of our specialties here at MPG. We provide psych testing, ABA, behavioral and educational services, and a whole bunch of others, as you see in this list here, such as CBT, PCIT, SPACE, social skills group, and so much more. And our payment options also vary. We have private pay, and we also take commercial health insurance and DOE and partial hearing order payment options. Our vision at MPG is to create a future where individuals and families feel supported, connected, and empowered. And our mission at MPG is to provide multidisciplinary integrated support for individuals and their families who all experience these mental health, behavioral, and educational challenges. So I'm really happy and excited to present to you today's speaker. Dr. Ariel Kornblum is the Senior Director of Clinical Operations here at Manhattan Psychology Group, and she is also a board-certified behavior analyst. In her role, she supervises a team of behavior analysts, therapists, and educators who provide support for learners from ages 2 to over 21. And Ariel has offered various therapies and interventions, including CBT and, of course, applied behavior analysis. Her areas of expertise include behavior management, anxiety and depression treatment, and working with individuals with ADHD and autism, and pathological demand avoidance, which coincidentally is the topic of today's webinar. So without further ado, let's all give a warm welcome to Ariel to kick off tonight's webinar. All right, Ariel. Let me just stop sharing.
Hi, everyone. I'm just going to get my slides up. Okay, so welcome, everyone. Tonight, we're going to be talking about PDA, which is pathological demand avoidance. And specifically, we're going to talk a little bit about differential diagnosis, what PDA is, what is the key diagnostic criteria for it, how to differentiate this diagnosis from other similar diagnoses. We'll talk a little bit about best practices for treatment planning when working with an individual who does fit the criteria for a PDA profile. And we'll also talk a little bit about resources. So where to get some training, advocacy, where to refer some clients to if they're looking to understand a little bit more about the PDA community. So I'm going to throw up the first poll because I'm really curious. Have you ever heard of the diagnosis PDA? Okay, wow. So we're leaning more towards people who have heard of the diagnosis. This is super interesting to me because, just a little backstory. The first time I ever heard of this diagnosis was maybe 3 years ago, and I was working with a family who had said, we think that our child fits this criteria. And that is when I really started on the journey of understanding what PDA is, what it looks like, and how we can, assess for it. And I think in that time, sort of the knowledge that people have of PDA, or they've maybe heard it a little bit thrown around, lots of families have at least, has certainly grown. So it's exciting to me to see that over 60% of the people here have heard of this diagnosis. So, well, what is PDA? So PDA, like I said before, stands for Pathological Demand Avoidance. Technically speaking, it is a subtype of ASD, of autism spectrum disorder. And the number one thing to know about PDA is that it's characterized by extreme avoidance of demand, any kind of demand. And we're going to go into a little bit what kinds of demands those could be and what it could look like. But essentially, we're looking at this avoidance of demands that doesn't really make any sense in the context of behavioral science. Some of what we're used to, either for BCBAs or psychologists, doesn't really fit in. So PDA is a common, well, it's not common, but it is commonly diagnosed in the UK. It is absolutely accepted into their medical diagnostic system there. It is not something that is included in the DSM. So this is definitely a big point to remember. There is no coding for PDA, and that is something that we need to consider when we are doing treatment planning for our clients. So what do we see when we see PDA? So we do see the presence of the ASD symptoms, restricted and repetitive behaviors, all kinds of social deficits, but it's really, and the way I describe this to either to clinicians or families, it's PDA is essentially a trifecta. One piece of it is the symptoms of ASD that are definitely there, meeting criteria, clinically significant anxiety that really has impact on day-to-day, and then really extreme sensory sensitivities. And that can be hypersensitivity or hyposensitivity. I see someone raise their hand. We're going to leave the Q&A until the end, so I might get to it. I hope I do. Like ASD, PDA is a spectrum. Individuals who fit this profile will require different levels of support at different points in time. But it's something to be aware of, that we can see really, really extreme presentations of PDA, and then we can see not so extreme presentations. And actually that makes classification pretty difficult. So what are the big symptoms? The first one, and this is really important, is, so if you're looking at, let's say a family comes to you for an intake and they have reports and assessments and neuropsychological evaluations. These are some of the things you want to look out for. So the first thing is having average to above average cognitive ability. So we're talking about any sort of standardized measure. These individuals will likely come up, not even really with big ranges, not even big standard deviations of difference between the different kinds of IQ, but really a average to above average IQ, full scale IQ. Ability to communicate utilizing vocal language. These individuals, for the most part, they use spoken word to communicate. We see extreme avoidance of day-to-day activities that seem to fluctuate regularly. It's like on some days, they can do a whole lot of things, and other days, everything just sort of seems pretty difficult, and it's very hard to decipher any sort of regular pattern to that. We see control, an extreme desire for control that is really driving and motivating a lot of the behavior. There is a desire for socialization, but there really aren't skills there, below the surface. So individuals who fit a PDA profile, they may be pretty good actually at surface level socialization, making small talk, sort of understanding what to say in different contexts. But when it comes time for really, maintaining relationships over time, that's much more difficult for them. We see a high degree of masking behavior. This is something that is super important to keep in mind, because this level of masking can oftentimes make it seem that they don't even have an ASD diagnosis. That's how important masking is to your consideration when making a PDA diagnosis. This behavior, the masking, it's both physically and emotionally exhausting. So you will see high degrees of restraint collapse for individuals, children, adolescents, adults who either go to school or they go to work and they manage to, fit what is expected all day long. But when they get home, they just completely fall apart. So tantrums, things like that. We see a lot of comfort in being online, utilizing social media apps or the internet to meet people, meet lots of people, but not to really, again, take it to the next level. A more in-person, unstructured social event is something that individuals with PDA will likely be avoiding. And we see a lot of sensory sensitivities, things like very sensitive to like temperature outside or style of clothing they need to wear, or very picky with certain kinds of textures with eating. You want to be on the lookout for sensory sensitivities that are really problematic, meaning that if you have a parent in your office giving you some background, it seems clear that the sensory sensitivities are really impacting day-to-day functioning. So another big thing to know about PDA is that the demand avoidance is sort of first and foremost. That is what your initial, what the initial complaint will be from either from families or from schools or from, workplaces, is that there is just this avoidance that appears oppositional. So many times we will get, reports that there's just oppositionality all the time. And what our job really is as clinicians is to figure out why, right? Like, why is there oppositional behavior when it doesn't really quite make sense, doesn't really fit into a behavioral mold or a pattern. But really what it is the avoidance is rooted in anxiety and sensory sensitivities. And what is motivating the oppositionality is the need for control. And that is what we constantly need to come back to and keep in mind if we are working with an individual who fits the profile for PDA. These challenges, the demand avoidance, the anxiety, the sensory sensitivities, they are very much exacerbated by the ASD symptoms. So we're talking about deficits in receptive expressive language, pragmatic language, social emotional challenges. These things are layered and they really make it difficult for, day to day for many of these individuals. Also, many of them, for the most part, children, adolescents, adults, if you meet someone who fits a PDA profile, they really appear to have age appropriate social skills. They really understand what to say in given moments. Like I said before, the masking is really significant, that they have spent years really learning those skills. And that can be really difficult at first when you're trying to do some case formulation. They really do struggle with articulation of their feelings and their emotions, problem solving, really getting to the place where you can work on both being aware of and actually working on the underlying anxiety and rigidity is very difficult as a clinician. So I actually pulled both of these quotes from the UK Association for Individuals with PDA, because I thought that they were really representative of what the experience might be like and what I have heard from individuals that I have treated myself who fit this profile. So the first one is from an individual named Tony. I like to describe the experience of being under a demand as similar to having claustrophobia. The anxiety keeps rising steadily until it becomes a non-negotiable, panic-driven need to flee from the source of the demand. And the second one is from Isaac. I feel most anxious when I'm pressed to do something I feel I can't do, But when people around me don't understand what I mean when I say I can't do that, I know how to do things and I can do them sometimes, but most of the times I just can't. It starts with avoidance, but if someone insists, I'll go straight to panic. I go from being okay to crashing down a hill. It's the most frustrating thing to have the functional capacity to understand what's happening, but the functional ability just isn't there. It is the worst form of self-sabotage. And these experiences are super similar to what I hear from many of the adolescents and young adults who I see who feel that they fit this PDA profile. They constantly feel frustrated that they sometimes can do things and other times they can't, but that the world really constantly expects them to be meeting an expectation that is very, very difficult for them to meet. And that is because the appearance, right? The initial sense that you get of social skills, and like I said, average to above average cognitive ability and, spoken language really allows like the world to think that or expects them to be able to do something that they might not be able to do. So a big, big piece of PDA is psychoeducation to the people in the community, the individuals' families, their schools, their community, to really have people understand, well, what does this mean, right? Most families, schools, community centers, they understand what an individual with level 3 autism might look like. They can see that, they can understand that. It might not make them, good at handling some of the behavioral challenges, but at least there's an understanding there. And with PDA, there's really this consistent feeling from individuals that they are just really misunderstood by the environments that they live in. So what are demands? This is such a great question that I really wanted to put out there, because when you think about it, we really have to think hard about what demands are. Again, we're talking about a diagnosis that is pathological demand avoidance. So demand is the big word here, right? Demands in PDA, they are many and they are cumulative. They are all day, every day, and they are relentless. And I wanted to really break it down so we could think very broadly about what demands are. The first category, direct requests or questions, very simple. We all understand what that means. Clean up your toys, come to dinner, go do that, go use the bathroom. Those are all requests, right? So if we see avoidance of a direct request, that's very simple. Most people can understand that one. But then there are more indirect demands. And the one that really comes to mind a lot that you could see all over the research, but is also something that anecdotally I've experienced many times, is actually reinforcement can be somewhat of a demand. Social reinforcement, even labeled praise, which is we hold up to be something that is really an excellent form of positive reinforcement, can be demanding to an individual with PDA, because it sort of places this future expectation that the individual who gave that reinforcement will want to see that behavior again. Uncertainty has been pulled out in the research on PDA time and time again. We all know, something I say in my office all the time if I'm working with a family of a child with anxiety is that anxiety lives and breeds in the unknown. If there is uncertainty there, or there is something that is unknown, our anxiety will just skyrocket. And for anyone who has experienced anxiety or struggles with it, regularly, knows that to be true. Uncertainty is very, very difficult to deal with. And uncertainty is very important when you're considering a PDA diagnosis, because the anxiety of it is so demanding for an individual with PDA that we start to see avoidance in a way that feels like one of these moments that people will say, well, it just happened out of nowhere. The behavior happened out of nowhere. But no, the anxiety is really driving it. Demands within demands. This is a great example of this is going to the movies. So if I'm a kid and my friend asks me to go to the movies, that's a demand, right? It's a question. But let's say I want to go to the movies. There are so many demands within that demand. I have to figure out, how to stand on the line and actually make a decision about if I want popcorn or I want candy or I want both. I have to choose a seat. I have to sit in that seat. I have to think about, well, how am I going to get out of this seat if I need to use the bathroom? I don't know how long this movie is going to be or how many previews there are going to be. There are many demands within demands. And if you really start to think about it, and for all the BCBAs here, we live in a world of task analyses where we could break anything down into a lot smaller parts. You could also break demands down quite significantly. The next is the I should daily living. I should take a shower today. I should make my bed. I should do the laundry. I should make something substantial to eat instead of ordering in. Their shoulds are never ending, and they only build up throughout the day. They're cumulative. Again, they keep coming and coming and coming. Internal demands. If I'm sitting and I feel like I need to use the bathroom, that could be a demand. That's my body really demanding something of me. I'm hungry. It's my body demanding something of me. These are things that play very heavily to individuals with PDA. And something that I want to really recognize here is when we're thinking about, like, as BCBAs, we're thinking about, functions of behavior. Lots of these things don't fall into our typical analyses. So they really, really need to be in the forefront. We need to be cognizant of that and make sure that we are actually considering things that are outside what we might typically consider. The last one is things we actually want to do. And this one you saw with some of those quotes before, and it's something I hear often from families and from individuals that I work with, which is like, I really want to do that. I really want to go ice skating, or I want to go to a movie, or I want to go to the museum. And they feel frustrated that they can't actually do the things that we want to do. And again, this brings in really to the forefront this question of motivation, right? Which is something that we consider with any sort of behavioral intervention. We're constantly assessing, well, what is one's motivation to do something, right? Is what's the reinforcer that's motivating it? And sometimes, like, what I'll hear and what I'll see is families and schools say, well, I held up basically like the biggest carrot I could, and he or she still didn't do it. And then we sort of all are, scratching our heads like, why? That doesn't really fall into, what we understand to be the science of behavior. So we also need to understand that demands are not always, things that we would think could be avoided. They might actually be things that we want to do. All right, the first code word is the word demand. Leave it up there for a few more seconds. Okay, so we've talked a lot about PDA. We are mostly clinicians on this, on this call. So let's talk about, well, when do you consider it, right? I said before that PDA is a subtype of ASD. And that's really important, but it's also important to understand that many individuals who fit a PDA profile may not have that ASD diagnosis when you first meet them. Actually, I would say more often than not, they won't. And that is because of what we talked about before, which is, this average to above average cognitive ability, as well as that masking behavior. So in my experience, the neuropsychological testing will show maybe one or many of these disorders. ODD comes up first and foremost, oppositional defiant disorder. As a clinician, I have certainly a gripe with this diagnosis. It's really a catch-all for individuals that we don't feel like we could accurately diagnose. That along with conduct disorder, those two are really difficult. If you see those on a neuropsych, my first instinct as a clinician is, well, I have questions, right? Next thing is ADHD. Lots of ADHD overlap in symptoms between ADHD and ASD, ADHD and PDA. Generalized anxiety disorder, clearly, right? We have a large degree of anxiety here. You might also see, things about sensory processing disorder, which is another diagnosis that is not formally in the DSM. But you might have a child or an adolescent that has a history with receiving, occupational therapy all the time, right? Like 2-3 times a week because there is a sensory need. So that's something to look out for as well. So I would say if you see any of these things on an intake form, any of these diagnoses, just have a little bit of a question, right? Like that, these could warrant some further investigation. So when should we think about PDA? The first thing is traditional behavioral treatment is not effective. ABA is the gold standard treatment for autism spectrum disorder. It is not the gold standard treatment for PDA. And that is very, very, very important as you start to think about treating this diagnosis. So anything rooted in behavioral principles is not going to have the intended effect, or it's not going to be linear. Like you might see some progress, one of these things that's 5 steps forward, 10 steps back. So I listed a bunch of psychotherapies here. PCIT, parent-child interaction therapy, parent management training, PMT, supportive parenting for anxious childhood emotions, SPACE, cognitive behavioral therapy, and acceptance and commitment therapy. These are all wonderful therapies. And as a clinician, I'm not trained in PCIT, but I'm trained in everything else, and I use them all the time. But you need to be aware if it's not really working as you feel like it should. And there's no other reason for that, right? We have buy-in from families, and we have a good rapport with the client. We want to be thinking about why that is. So again, progress is not linear, right? Some days we have clients, they get up, their alarm, go to school, eat 3 meals, do their homework. And other days we can't get out of bed. And that is the reality of a PDA diagnosis. It is something that before you have context for why those things are happening, it doesn't really make a lot of sense to the individuals and caretakers and school teams. And it can be very frustrating for those people. Masking is either highly suspected or is reported by the client themselves. Something that I think is really, positive that's been happening in the past few years, at least in my practice, is masking is much better understood both by families, the clinical world, and also by clients themselves. I hear a lot about, especially if I have a teenager or an adolescent, a young adult in my office, they will talk about masking. I think that's in part due to a lot of that being on social media, but I do think it's positive that people think about masking. The next thing is we get reports that the behavior is occurring in a vacuum. We don't know what happened, right? There's no discernible antecedent or consequence, and we can't really figure it out. Like we could do ABC charts, we can do scatter plots, and it just sort of, it's elusive. We can't figure out why it's happening. Rewards in particular are ineffective. This is a big one and has been a flag for me clinically over the last few years, every single time as part of the intake. Rewards do not work with my child. They have never worked with my child. If you hear that, that's sort of an instinct. You should be asking more questions about that. The client is able to succeed socially on a very superficial level, but the deeper relationships are much more difficult to build and to maintain. And what you'll see is a lot of forming these, friendships or quick relationships on either, some form of social media that either never come offline, they never go into real life, or they just peak and then they disappear, and they peak and they disappear, and it's with lots of different people. So they are like individuals with PDA, they are social, they want to be social, and they often initiate that kind of social interaction, but the reciprocity is much more difficult. The last one, there are qualifiers too. A traditional educational environment, for the most part, it is pretty dependent on a set of pretty strict rules, routines, discipline codes. We do have school-wide positive behavior supports for the most part in most schools these days. But any sort of those traditional positive behavior support system, disciplinary codes, tons of expectations about transitions throughout the day, that can be much, much harder for an individual. So if you have an intake for a client who's really struggling with their school placement, or they have a degree of restraint collapse in the afternoons after school that is really untenable for families, like they just cannot have like these huge meltdowns every single day, it's really, it's really time to think about getting involved in terms of making recommendations for, well, maybe this isn't the right school environment, or how can we modify this current school environment to make it work for the individual? Okay, So diagnosis. PDA, oh, hold two, wait, sorry, I went back one more. Okay, so PDA, it's a clinical diagnosis. There are no specific measures that are just for PDA. So I want to be clear that it's very important that if you are a clinician that is a diagnosing clinician, you need to be aware of all the symptoms and how they overlap so that you can really make a differential diagnosis. So there are handbooks out of the UK that really go through symptoms. But for the most part, if you're going to see a ASD diagnosis, it's going a PDA diagnosis, it's really going to say something like autism spectrum disorder with a PDA profile or characterized by extreme demand avoidance. You'll have to see some sort of qualifier in the diagnosis section. So traditional assessment tools for ASD are helpful data points, helpful starting off points. Like I said before, many individuals with PDA won't actually qualify for an ASD diagnosis with traditional tools like the ASRS, the ADOS, or the CARS. So we have to consider that to be one data point. We need to assess anxiety. There are tons of tools for assessing anxiety. Something that I really like to include is this measure, which I have, I believe, a link to it at the end. It's called the CAT-Q. It's a masking measure. And I think that this is really, really important to do in conjunction with ASD testing to really see if masking is off the charts, then we need to really question the results of the ASD testing. We need to have input from other professionals, understanding pragmatic language skills, sensory difficulties. These are things that are very important when making a differential diagnosis. Now we'll go to the poll. Has a parent ever asked you about a PDA diagnosis for their child? Okay, so I'm going to end it now. What I think is really cool about this is 73 people on this call have had parents ask them about a PDA diagnosis. My experience and my findings are actually, there's a lot of online support for families who are considering this diagnosis for their child. There are low demand parenting groups and Reddit threads and Facebook groups. So this is really interesting to me that 73 people have been asked this before, and that really signals to me that we need to be doing a lot more education on what a PDA diagnosis is. So why is diagnosis important, right? It's important for a lot of reasons, but in this case, it's really important because traditional therapies might actually do more harm than good with a PDA population, and that's really important to keep in mind. Assessment always needs to inform intervention. We need to understand our client's strengths, their weaknesses, where the gaps are, so that we can really formulate treatment plans. With PDA, the diagnosis shows us that all of this behavior that potentially parents and school teams and caregivers have called, a child or an adolescent just oppositional, right? This clarifies that some of that behavior, most of that behavior is not within the individual's control. It helps families, caregivers, support staff understand specific situations, right? Know your child or adolescent's triggers so that they can plan accordingly, which is really, really, really important and empowering for our families. And it allows access to more individualized supports. That's inside school, outside school. Having an understanding really gives context to the way, not only the specific treatment that we are doing, but also the way that we organize environments and the way that we expect behavior within specific environments. So let's say we get to diagnosis, right? And we have PDA as a working diagnosis. Well, what is the treatment? I said about a few minutes ago that traditional treatments can actually do more harm than good. And I think that's a really unfortunate truth about working with individuals with PDA. Many of them have been really put through the ringer in terms of very traditional behavioral therapies that have really done the opposite of being helpful. So what do we do, right? The first thing, and the by far and beyond the most important thing, is case coordination. When we do this at our office, when I do this, we refer to it as quarterbacking. What these families need, if there is a diagnosis of PDA, is they need someone that will coordinate between different service providers who will provide psychoeducation on what PDA is and make recommendations for how to organize the environment and what kinds of strategies to use. Parent training is really important. I said earlier, things like PMT, PCIT, and SPACE are not exactly indicated. Those are all parent training. Those are all parts of it are parent training. You can modify parent training to meet the needs of the family. So really having a clinician in there who has a knowledge of the behavioral training, behavioral parent training supports, but is creative in the way that they do it and is flexible and can pivot is really important. Again, we can modify CBT or ACT to meet an individual's needs. This one is very specific on where the individual sort of falls on that PDA spectrum, depends on their age and their willingness and awareness. I really find that individual therapy for PDA is most indicated for, older adolescents and young adults. Social skills training can be important, again, depending on where we fall on the spectrum. Executive function coaching. Educational consultation is a big one. The research shows us that individuals with PDA do best in project-driven, individualized educational programs where they can do maybe a lot of work one day and then not do some work the next day. And that can be, there's lots of different options for that kind of a thing. It's a little bit harder to come by, but having an educational consultant on board who understands the options can be really important. FBAs, again, important, but keeping in mind, thinking outside the box in terms of what functions of the behavior might be. ABA, this is a big one and a question that I get asked a lot. Many times, because traditional reinforcement of, positive reinforcement, these kinds of things are not indicated for PDA. That doesn't mean that we can't utilize ABA. There are unique and creative ways to utilize reinforcement that are not super demanding to individuals. And in my work, I have worked with some, many families who have chosen to utilize their insurance benefit and get ABA. And we have been able to, again, this is where the quarterbacking comes in, collaboratively make that therapy work for the client. And then we have OT, PT, speech. It's always very important to collaborate with other service providers, but particularly with PDA, because again, it's this trifecta of the ASD, the anxiety, and the sensory difficulties. It's so important to have the other providers' input. And then medication, right? So there's no pill or medication that's specifically approved for ASD or PDA, but there are plenty of treatments available for anxiety, and that can be a very important part of treatment for individuals with PDA. So what do we think about when we're developing a treatment plan? So the UK PDA Society, like I said, I think way back in the beginning, the UK is light years ahead of any other country in terms of their understanding of PDA, their diagnostic capability, and also their treatment. They have, specialized schools, they have PDA societies, and I'm going to link them at the end, but they have tons of fantastic information and handbooks for treatment. I actually did my training through them, and I would highly recommend it. So they have this approach called the PANDA approach, and I've put it here. So the P, pick your battles, minimize rules, enables control, right? Forced choice is a great strategy for an individual with PDA. Explain your reasons. And as individuals and as parents and caregivers need to understand that some things are just not going to get done, even if they were done very successfully a day before or a day or two before. The A is for anxiety management. The anxiety needs to be managed. It is very, very, very present and an undercurrent throughout all of the externalizing behaviors we see with PDA. So we need to manage it. And they have here low arousal approach. I will add to that there is a lot of times here in the US, we refer to it as low demand parenting, which is sort of how do you keep the demand just really low, reducing the uncertainty, recognizing the underlying anxiety, and doing whatever you possibly can to modify the environment, planning ahead, and supporting our individuals when they are having a meltdown. They say here to treat a meltdown or a tantrum behavior as like a panic attack. Negotiate and collaborate, right? These things are maybe not always indicated with a more strict behavioral approach, but when treating PDA, we need to do that. We need to keep calm. We need to be proactive. We need to understand, okay, this is not going to happen the way I want it to happen. So either I'm going to pick this battle or I'm going to work on finding a path forward through negotiation. So managing demands. I think everyone on this call would agree that demands are a part of everyday life. I went through an exhaustive list of demands earlier, and we just can't eliminate all of those. And it wouldn't be okay to not have any demands at all. So we need to find a way to manage them, right? So are we going to be low demand as much as possible and stick to the ones that actually need to get done? Can we disguise them a little bit or manage them in a way that gets us more, compliance in the end? Doing things together can help. With the families I work with, we talk about this idea of monitoring tolerance for demands on a day-to-day basis. Some days we wake up and, most families, and this is not a clinical term at all, there's no assessment for it, but most families will tell you that they have like a gut feeling that they can push their child a little bit more on certain days. So we talk a lot in treatment about taking advantage of those moments, monitoring the tolerance and knowing when to push and when to back off. And that is an assessment that needs to be ongoing all day, every day. Adapting, have a plan B, plenty of times, leave plenty of time if you know that you're going somewhere that's going to be triggering. Humor is great, distraction, novelty, being flexible. All these things are, widely applicable to lots of different diagnoses, but really important for PDA. And I also put here the CPS model, Ross Green's collaborative problem solving model, where you come up with a plan B, is actually really wonderful for PDA profile as well. Again, you're going to take bits and pieces from certain kinds of interventions and adapt them to meet a family's needs based on where their child is falling on the PDA spectrum. The second code word is lifestyle. So the key elements of treatment, I went through a pretty big list of what kinds of treatments might be applicable, but the most critical component of treatment is responsiveness. This is that monitoring I was talking about before. We need to constantly be monitoring tolerance for demand. Avoidance fluctuates regularly. Some days we could be all avoidant, and some days we have ups and downs. Sometimes we see different levels of avoidance within one specific small time period or one activity. So anyone that works with a client who has a PDA diagnosis needs to understand what's going on with their client, need to be aware of the triggers, how to recognize when someone is feeling a little bit more anxious, and how to respond to that. There is nothing more important than responsiveness if you are treating an individual who has a PDA diagnosis. And because of this, working with an individual like this, I would suggest really requires team meetings on a far more regular basis than we are used to with other diagnoses. The goal of treatment for PDA is not to fix it, it's not to eliminate the symptoms of PDA. Like ASD, PDA is a form of neurodivergence. We need to understand our individual's set of strengths, challenges, and partner with them. So that is something that's really important and really unique to PDA, which is this, there's this idea that we have this average to above average cognitive ability. We have the desire to be social, and we have social, vocal communication, and we can really utilize those strengths to partner with our clients to get them to set their own goals and to support their autonomy. And these are very important parts of treatment. The partnership looks different, but we need to approach treatment with empathy, respect, anti-ableism. There are many of the individuals who, speak out about how detrimental their experience was with ABA was for them actually fall into a PDA category. Many individuals with PDA do tons of speaking engagements and they write books, and you could read, and I listed those resources for that information. And what we need to take away from that as clinicians is that we need to have empathy and responsiveness above anything else. The prognosis for PDA, it's a lifelong diagnosis. Like I said before, it's not linear in terms of progress. We need to be working with our families to talk with them about planning for the future, right? We need to work with older individuals on advocating for themselves. Something I talk about a whole lot with the families I work with is, well, the age of remote work and hybrid work and flexible work is something that individuals with PDA can really use to their advantage. There are lots of jobs that are project-based, which is a good fit for individuals with PDA. So the sooner that we understand where the strengths and the challenges are, the sooner we can work with our families to really build for their futures and really have that autonomy. So resources. The PDA Society in the UK is fantastic. That's what I was referencing before. There is a North American PDA Society. They are fantastic as well. They actually just launched their own training CEU course, which I heard is great and similar to the UK one. They do a lot of advocacy here in the States for inclusivity of the diagnosis. So I would definitely check them out as well. And then these are a few books, a couple of books that I've read that really get into what the experience is like to have PDA. These books are great. And then if you click on this website, there are tons of blogs and vlogs and social media accounts who are run by adults who have diagnoses of PDA. I have found in my work that I have gone back to these time and time again to just read and remind myself about, what it is like to have this diagnosis on a day-to-day basis. And that's why I pulled out those quotes before. But all of these resources are great just to get some additional education. So my goal was to leave 10 minutes for questions, and we have 13 minutes. So we're in good hands. If you have a question, please put it into the Q&A chat and I'm going to run through them. Okay. The first question is, what are examples of other diagnoses like PDA available in other countries but not in the US? I'm actually not sure, but one that comes to mind, which I don't know if is anywhere else, but is sensory processing disorder. That's something that has not made its way into the DSM. The second question is the cognitive ability criteria for PDA determined by IQ testing? Yeah, we're talking about norm reference standardized IQ tests, things like the WISC, the Stanford Binet, and anything between an 85 and a 115 is considered to be average. Can those with non-vocal communication or considered nonverbal have PDA? Yes, but much less so. Next question is, what is the difference between ODD and PDA? Great question. I think I said this before. I'm going to say it again. ODD is a catch-all diagnosis. The criteria for an ODD diagnosis and a PDA diagnosis and an ASD diagnosis, there's so much overlap there. It's very difficult to say what the difference is. It's more about how to make a differential diagnosis so that you can provide better treatment. And this is really the important piece. If someone comes into a behaviorist office or a psychologist's office with a diagnosis of ODD, myself included as a BCBA and a psychologist, I'm thinking behavioral strategies. What are we going to do here? Younger kiddo, we'll talk PCIT, we'll talk PMT, but we're talking, behavioral strategies. If I did that with someone who had an ODD diagnosis but really had a PDA diagnosis, I would really be doing them a disservice. So if you see ODD, certainly think about the behavioral strategies, but also think about what else might be going on. That's not to say that everyone who has ODD has PDA. They don't, but it's something to think about. Is there any particular reason that the DSM-5 does not recognize PDA? I don't know if there's a particular reason. I think it has something to do with the fact that they got rid of all the subtypes of ASD when they changed from Asperger's and things like that. But I'm not sure. Next one is, how can one gain further in-depth education on having a better understanding of PDA? This is a fantastic question. And I would recommend doing the training either through the PDA Society in the UK or PDA North America. These are trainings you do, they're online. They have, tests and mastery criteria and things like that, and they're very comprehensive. Next one, these symptoms sound exactly like PANDAS. Is a strep test part of the diagnostic process? I'm going to answer that one first because it's 2 parts. Yes. So, if anyone is not familiar with PANDAS or PANS, there's a lot of very, big picture. There's a lot of behavioral challenges that tend to come up very quickly after a child has had strep. So you could do a strep test. If the behavior that you're seeing feels new and really off the charts and really not typical of that child, then yeah, I would recommend, a PANS or a PANDA test. I don't do it very regularly, but I actually have a client myself who has a PANS diagnosis right now. So we recommended that. The second question is PDA something the parents will report symptoms from a young age? Yes. You will see in intake appointments, in neuropsychological assessments, parents talking about extreme demand avoidance from a very young age. And you'll see things like sleep being really difficult, feeding being really difficult, colicky behavior, all those sorts of things. Next one is there any research regarding skills-based training with PDA clients? Yes. So on these websites, you can definitely see that, but it's not going to be your traditional behavioral skills training where you're providing, breaking it down and providing reinforcement. It's going to be much more going with the flow in terms of where they're at in terms of their demand avoidance that day. Next one is, can you share research articles if there are any available? Yes, there are tons of them all over these sites, so I would check them out. Do you have any resources for siblings of those with PDA? I would say that like any sibling support group for, siblings of individuals who have any sort of, you're diagnosed with any sort of neurodiversity would be indicated in these cases. I want to make sure I have time. There's a lot of questions. This is a great question. Male versus female features, are they similar? Yeah, they are similar, but keep in mind that females are much better at masking. That masking tool, use it if you have an inkling that an individual in your office, a female, might have, autistic features or a PDA profile. Certainly talk about the masking. I have found in the last 4 years in my practice, I'm seeing more and more females who fit criteria, and that is only because we're talking more about masking. What is the best way to classify the appropriate school environment? It's a really good question. It really has to go with like where you're at in terms of that spectrum. There are individuals with PDA who are in very flexible mainstream environments that are able to do exceedingly well there. And there are other individuals that really require a one-to-one. Do you think Greg Hanley's My Way touches upon this? I have a student who gets aggressive out of nowhere with any demand, 4 years old. Yes, I think Greg Hanley's work is incredible and applicable to PDA. But again, you have to keep in mind that some of the more traditional behavioral constructs are not going to be a fit here. Are all PDA organizations and treatments ABA based? No, quite the opposite. Most of the organizations for PDA really put forward, things like low demand parenting. If PDA behaviors do not fall under a function, how could a BCBA treatment plan for PDA? This is a fantastic question. And I would keep in mind as behavior analysts, we need to widen how we're looking at functions of behavior, right? ACT, acceptance and commitment therapy, which is a fantastic treatment for anxiety, is within the scope for BCBA. So we need to be educating ourselves so we can include things like anxiety in our functional assessments. You're going to do that in conjunction with other professionals, but it's certainly something to keep in mind. How do behavior analysts determine the difference between PDA and a learning history where escape has been heavily reinforced? Are they one and the same? No, if there is very thick learning history, it would be, and that's what was going on, that would be responsive to behavioral treatment. So you sort of have to, see how that goes. How would I go about trying to get my son assessed for PDA? The main place that diagnoses ASD has not heard of PDA before. Your best bet is to go on the PDA North America website, find a clinician who is educated in PDA, and see if they will do a cross-state consult with you or they're licensed in your state. Okay, I really like this question because it's so true. It seems like there's a significant demand on parents' time, effort, and helping manage their child's PDA. Yes. Managing PDA as a parent is extremely burdensome. And my best advice for these families is to find a great quarterback. Find someone who can take on some of the burden, right? What happens a lot is parents fall into that de facto quarterbacking, position, and they're the ones who are educating. Oh, child's new teacher, I have to educate them about PDA. New therapist, I have to educate them. Like, they are doing all that work. If you have a clinician who knows your child and knows your family really well, they can take some of that burden. And that is what, anytime I talk to a parent, if I say you're going to put your resources anywhere, put them into finding a quarterback. When you say a diagnosis of PDA also has an anxiety disorder, are you specifically saying it would be a generalized anxiety, or could it be other diagnoses like separation anxiety? It could be any anxiety, but it usually looks like generalized anxiety. Only have maybe like one more question. Let's see what's new here. Want to answer this one quick? Oh, yes, I will link the cat Q in the chat. So there's a lot of while I'm pulling up the cat Q, there's a lot of questions in here as well about what are presenting symptoms and what do you see, and at different ages. And what you see is primarily what we talked about, which is the avoidance. And something that's so important to recognize about that is that it could look different at different ages, and it could be more severe or less severe at different ages. So you really want to look at some sort of a pattern of behavior that is not responsive to any sort of traditional behavioral treatments. I'm going to put this in there. So if you have, a family that you're working with, let me just stop sharing, and they, have a child who's in preschool or school age, and they are constantly avoiding demands, and parents will say, or teachers will say, well, there's no, there's just no rhyme or reason. It occurs in a vacuum. I can't figure it out. And, that is when you want to start to, think about it a little bit more. So it can look like, it's just going to look at like avoidance. So if you see avoidance, that's when you want to start to think about it.